Okay, can everyone hear me? Yes, beautiful. Welcome to our late-breaking abstracts session on transplant and health services. There are a couple housekeeping notes. My name is Delphine Tuo. I'm a professor of medicine at University of California, San Francisco. It is lovely to be here, and welcome. Just a few reminders, download the NKF Meetings mobile app. It does make life a lot easier to fill out your CEs and get your credits, as well as scheduling. Presentation slides will be available on the mobile app as well. If you're on social media, don't forget to post with the hashtag NKFClinicals. And that's it. All right. And I am excited to get started with Dr. Diametides. You want to go on? So Clarissa Diametides is a professor of medicine at Wake Forest University School of Medicine, and she also directs the Maya Angelou Research Center for Healthy Communities. And she is interested largely in using digital tools to try to mitigate disparities in chronic kidney disease and population health.
Thank you. How do we do this? Is there a method to this? Here we go. Keep going. Yes. Okay.
Let's do this. And you are off.
Okay. Thank you, Dr. Tuo. Thank you, everyone, and thanks for the opportunity to present a little bit of our work where we are describing some early work using artificial intelligence to address social risk in kidney transplant. So the title of my talk today is Leveraging Large Language Models to Identify Barriers to Kidney Transplant in the STEP study. And this is a project that was done as an ancillary to a large clinical trial, predominantly with our partners at Duke University and Wake Forest University, both in North Carolina. We have one disclosure here. One of our partners has co-ownership of Layer Health. There's nothing else to disclose except I will disclose that I am a nephrologist and not a computer scientist, so that is a disclosure that I very importantly need to make at the beginning of this abstract. So our goals today are to understand how the STEPS clinical trial was designed to address social barriers to kidney transplant, to understand how large language models can be used to evaluate contextual factors in documentation within studies, and then to understand a little bit about how LLM models can uncover process gaps and improve outcome tracking in research. So first, I need to tell you a little bit about the STEP study in which this smaller project was based. So STEP stands for System Interventions to Achieve Early and Equitable Transplants, or STEPS. The PI of this study is Dr. Ebony Boulware, who's an internationally recognized researcher in kidney transplant and equitable transplant care, and serves as Dean of the Wake Forest School of Medicine. So the STEP study essentially tries to overcome barriers to equitable kidney transplant through integration of social work and transplant coordination early on for individuals who are not yet on dialysis. So in general, the idea is that we identify folks early, and we do this through integration with the electronic medical record, where we're scanning medical records among our participating health systems to identify folks based on their medical data who might be eligible for a kidney transplant. And then the intervention itself involves a social worker who then reach out to individuals who are at high risk of adverse outcomes, educate them about kidney disease and their potential candidacy for kidney transplant and why we want kidney transplant to be our preferred treatment for kidney disease. The social worker also helps to address medical and social obstacles and then direct them to the transplant coordinator when appropriate. And then for individuals who have an eGFR of 20 or less, they also have an interventionist who is a nurse transplant coordinator who helps those individuals navigate through the very complicated steps needed to get to the kidney transplant center. And the main outcome of our study are completed transplant evaluations. In this case, it's really, I would consider transplant evaluations by definition to mean more of having an interaction with the transplant center, so even being referred and screened regardless of whether you're eligible or not. And so the study is a randomized comparative effectiveness trial, and we recruited from 3 health systems: Duke University in Durham, North Carolina, Geisinger Health in Danville, PA, and University of Mississippi Medical Center in Jackson, Mississippi. We recruited adults aged 18 to 74 who had kidney function of less than 30 or a kidney failure risk equation score of greater than 10% based on the Tangri risk equation at 2 years. Again, this is for folks who are not yet on dialysis. We excluded folks who had a prior history of kidney transplant. And individuals were identified through our health system sort of registry data embedded in the EMR. I'm happy to report that the study is actually over. We finished our recruitment of approximately 1,200 participants in March of 2024, and our intervention completed in September of 2025. And we're in the process now of, we just closed all our data, and we're in the process of analysis looking at outcomes. So that should be out shortly, hopefully. In this study, however, the one I'm describing today, we did a small ancillary study within the STEPS, the larger STEPS clinical trial. And really, the issues related to what we were finding within our very rigorous documentation within the clinical trial was that there are contextual factors that we really could not discern using what we embedded as standard data elements within our EHR. So, for example, a social worker would see a patient, a participant, write their note using drop-down boxes, et cetera, and then there would be some free text at the bottom, which would give a little bit more context regarding how that encounter went. The standard data elements we could very easily extract and look at, right? And those are quantifiable. But the free text and the context, I think it's probably a better way to say it, were much harder for us to evaluate, and it was very anecdotal. We'd have an interventionist say, oh, I met with Mrs. So-and-so, she was very tearful, and she was very excited about, you know, this study giving her hope, et cetera, but there wasn't a smart data element for hope, you know? And so we really could not identify or really capture that experience of being in this study. So what we did, we used data from Duke, or one of our 3 sites, and we applied a large language model to analyze and group the social barriers identified in social work notes, both in the intervention and usual care at Duke Health. So we first extracted social work notes again, from both usual care within the health system and those in the intervention arm, as we said in between 2022 and 2025, and we used OpenAI, Azure OpenAI, which is just a pretty commonly used large language model software. We then took quotes within the free text component of our study documentation, that related to 5 very commonly seen social barriers. This included financial barriers, social and emotional barriers, barriers related to knowledge and learning, barriers related to transport or scheduling, and barriers related to drug or alcohol. And so the large language model then took this very complex cluster of free text and, train of thought documentation and generated thematic clusters based on that of challenges encountered within those notes and proposed solutions offered by the social worker. And so they then were able to compile barrier-specific narratives using the text and sort of these thematic extractions. And then the large language model then could take each of these narratives and see what information is there to support that folks were facing this barrier, for example, drugs and alcohol. What solution was potentially offered by the social worker and whether the issue was resolved. spoiler alert, we did not really capture issue resolution yet in the current data, and so that is not reflected here, but that is something that we're working towards because of the need for longitudinal analysis. And what do we find? We found that if you look at the figure 1 to the left, sorry, it's kind of backwards, we noted that folks in the control or usual care arm saw a social worker about 31% of the time. Again, just to reorient you, these are people with advanced kidney disease, either stage 4 or high risk of progression based on a Tangri risk equation. Obviously, those in the intervention, because the intervention includes a social worker, had an interaction with a social worker 100% of the time. Meaning that in usual CKD care, we found that about a third of folks were seeing a social worker as often as in this study. And what we found, if you look to the figure on the right, is that across these sort of 5 domains or social barriers, there wasn't a real difference between folks who were in the control arm or folks who were in the intervention arm, except for this ascertainment of gaps related to knowledge and literacy. You can imagine that if you're not actually looking for gaps related to kidney health, then you will not find gaps related to kidney health. And so this was not a surprising finding that those in the intervention arm were more likely to sort of have documentation of some knowledge and literacy gaps. And I don't expect you guys to read this, of course, but what we then did was sort of identify across these 5 barriers whether there were red or this light pink sort of indicates the barrier, and green indicates sort of support that was given. So, for example, they would say, okay, I don't have I have a gap in health insurance, and a potential solution that was offered, and these are not one-to-one, these are sort of thematic, was that they gave information related to Duke financial assistance or affordable care. But this sort of nuance and granularity we could never have extracted based on the data elements that were in our trial, that we a priori put in our trial. And so in conclusion, what we found was that social workers address barriers 1/3 as often for usual care arm participants than those in the intervention arm. But the social barriers in terms of the density of social risk did not differ, right? So if you have advanced CKD, you have a high risk of social barriers. So what that means is that without such a intervention, there is a huge deficit, a huge gap, an opportunity for us to really embed social work intervention because the need is the same, but the encounters are fewer. And so with regards to large language models, this model allowed us to take this complex data, but look with much more granularity, much more closer examination at that free text, and really to incorporate sort of that lived experience really frankly in a quantifiable way, which we could not do before. It gives us a qualitative understanding of participant experiences, but it allows us to do so in a way that we can then relate that quantifiably to how it relates to our downstream outcomes. We can take the barriers that were identified. We can take the solutions that were identified now that they are actually variables themselves within our study and apply them to our downstream outcomes of transplant. So this is just one example of an application of how to use AI in a multi-site clinical trial. There are many ways to apply AI methodology, which I think there are some very exciting lectures on that while we're here, but just to give you an example, a real-world example from a pragmatic study. Thank you.
Thank you.
Are we doing questions?
I think we may have time for one question, if anybody would like, go ahead.
We considered doing something kind of similar at IU, but have found it really challenging to extract social worker notes. Do you have any best practices for working with systems to get that data?
It takes a lot of phone a friends. It takes a lot of favors. In truth, we are trying to do this at all 3 of our health systems, and we're only so far successfully able to get the notes from Duke. So And I don't know if y'all are aware that University of Mississippi had a ransom attack, and so their electronic health system went down. They went dark for about 5 days, and so they are now very hesitant to deliver any data to anyone, as you can imagine. But it really is a lot of, I don't have a quick answer. It's a lot of pleading. It's a lot of sort of showing that this is safe, that this is under the purview of the study. You know, this is not anything extra. So I empathize with your issue.
Thank you.
Thanks, guys.
Let's see here. Next presentation. All right, perfect. So our next presenter is Dr. Michael Ronklin. He is the Associate Chief Medical Officer for Value-Based Care at U.S. Renal Care and the co-founder of Rocky Mountain Kidney Care in Denver, where he has practiced nephrology since 2000. He focuses on patient empowerment and applying data-driven, value-based strategies to improve quality of care delivery.
Hi, everyone. My name's Mike Rocklin. I'm really appreciative of you all being here, and I'm excited to share with you our work on improving CKD care quality through risk stratification integration into the electronic health record. Our disclosures are limited to that the work was supported by Bayer. And let me frame what I hope you'll take from the discussion that the time I have. There's really 3 things. First, I'd like to discuss where CKD care execution breaks down. Next, I'd like to talk about how integrating a tool that combines risk stratification with clinical insights into the workflow at the point of care, how that changes medical decision-making by physicians. And lastly, what is the impact on adoption of these therapeutic opportunities that are guideline directed with an intervention like this? So we've never had more therapeutics than today to slow the progression of kidney disease and impact cardiovascular morbidity and mortality. Yet what we see is that utilization is still falling below what we really desire as a goal, and that there are missed opportunities. It's not an evidence gap, it is an execution gap. And so the challenge is, how do we turn that evidence into action? And so what we wanted to evaluate was whether we could take a tool, integrate data from the EHR to give the physician at the point of care risk stratification, so machine learning models, and combine that with evidence-based therapeutic opportunities and give it to them in their workflow and see how that would impact the adoption of those therapies. So this is our tool. This was our intervention. I'm going to start with that. It's called the Kidney Disease Progression Report, or KDPR. Today, I'm just going to focus on 2 parts of that tool. At the top is the therapeutic opportunities. This is much more than just a list of medications. This is where we have ingested from the EHR before they visit. We've ingested the labs for that patient, the medications they're on, the comorbidities, and their allergies. We synthesize that data and then deliver a new version of this tool into the EHR for the physician to use at the point of care. At the bottom, you see our risk stratification. This particular model, this is created by Pulse Data AI, is called the eGFR decline. What was special about this is if you look at the far right, you see that we are presenting not what we typically see, which is sort of like the idea of telling a patient you have a 60% chance that you're going to have a 40% reduction in your GFR in 5 years. that is difficult for patients and even physicians to really use. What we gave them is a visual, a very simple visual, where we had enough patients in our database to essentially have a near Gaussian distribution. So a people like me approach that's frequently used in financial reporting, we're able then to show them the mode, which is the peak, right? The peak probability of where they're going to be in 5 years. So on this is someone's data. You can see that they were stage 3A, then they went to 3B, and 5 years from now, when they see this, they can know now that the highest probability is they're going to be well into stage 4. By combining this visual UI with the therapeutic opportunities, we saw movement. Decisions were being made differently, and that's what I want to show you. So our study design was pretty simple. It was observational, it was descriptive, it was a pre-post study, and the intervention I shared with you. We looked at the period of this patient's care in the 18 months before, when there was no intervention, and then we just looked 1 year later after the intervention, what was the outcomes on medications. This was done in Texas at 2 very large nephrology practices, Dallas Renal Group and South Texas Renal Care Group, so Dallas and in San Antonio. We categorized patients per the standard sort of KDIGO guidelines, 1 through 5 for that practice. And our outcomes that I want to share with you are really, the 2 primary are, first, utilization of the tool by the physicians. Well, we were actually able to measure that. And then second, what was the impact on the 5 classes of drugs that we were interested in? So that was RAS inhibitors, statins, SGLT2 inhibitors, GLP-1 receptor agonists, and then non-steroidal MRA. On the right, I've already sort of introduced you to the tool. The only difference between the early CKD tool, stages 1 through 3, and the stages 4 and 5, the therapeutics were the same in terms of what we were looking at. But at the difference in the risk for the advanced stage, where we were predicting 6-month and 12-month risk of kidney failure. That's what we offered. All right, so we initially had about 11,000 patients that had a visit during the year. And our analytic cohort today that we're going to talk about is 10,375 patients that had visits during the year and then were still in the study at the end of the year. There were roughly about 550 patients, which are not part of this analytic cohort. Not including them did not change the outcomes in any way. And as we look to our manuscript, we'll be talking more about those patients. But for this conversation today, we're comparing the patients, these 10,375 baseline to 1 year later, okay? All right, so not surprising on the right side of this slide, these are nephrology practices. The staging leans towards more advanced stage, right? So the highest number were in the stage 3B. We had a good number in 3A, and then represented in 4, and then of course 1, 2, and 5 were lesser. Not surprising as well is the fact that these people were vulnerable. More than 90% had hypertension, more than 50% were type 2 diabetic, and more than 20% had documented cardiovascular disease. Now let's look at the baseline medications there on the bottom. 50% of these patients were on RAS inhibitors before the trial started. Over 60% were on statin. 18% were on SGLT2. 13% were on GLP-1. And just over 2% were on non-steroidal MRA. This is actually not that different than what you would see in the registry data that's available and been published. So it was it was what we expected. All right. So what I'm showing you here in the light bluish purple bars is the baseline data, and then the dark bars for each of the drug classes are at the end of 1 year. Meaningful increases in all 5 medication classes. Specifically, we saw for the SGLT2 inhibitors a near doubling to 35% for all these patients. GLP-1 receptor agonists increased by 50% to 19% for the population, and a near or more than a tripling actually for the non-steroidal MRA to 7%. So meaningful changes in adoption and prescription of medications after 1 year. What about for the the patients living with type 2 diabetes? We saw the same relative increases, but we achieved absolutes for these patients that were just, it was so meaningful. These are the patients that are most likely to benefit from these medications. So more than 50% of the patients had SGLT2 inhibition adoption by the end of the first year. GLP-1 receptor was up to 31% and non-steroidals at 11%. So what about, was this tool used, right? So you can see on the left, in the first month, we had an 8% utilization. But what was very exciting to watch over the last 2 years is a steady and sustained increased adoption by these doctors. So by the end of the first year, with the data I'm showing you, it was over 50%. I added for you guys just to see on the right-hand side, this is the next cohort 2 added into cohort 1, which took it up to about 15,000 patients. You can see in the last 6 months, we reached a peak of 65%, but for 6 months in a row, over 60% use of this tool at the point of care. Not on this slide, but something I'm super excited about. We decided after the study ended 4 months ago that we were going to continue to deliver the KDPR into those two EHRs for 15,000 patients. In the largest group with over 35 providers, more than 90% of their visits for the last 4 months, they have utilized this tool. In the other group, it's more than 65% of the visits they're utilizing this tool. It's a strong and powerful message to me that physicians need tools that actually synthesize data rather than giving them more atomic data to try to do in their head in less time. So these kind of tools bring meaningful change to care. We also were sort of excited to see what really looks a little bit like a dose-response relationship. So the lightest bars on the left are for patients that had visits during the year with no KDPR adoption. The middle bar were for patients that had one visit where it was used at the point of care, and the dark bars are where there were 2 or more visits during the year. And you can see there seems to be a dose-response relationship with a 21% higher adoption for SGLT2, 63% for GLP-1, and 84% for the non-steroidal MRA. All right, so in conclusion, really 4 things. 1, utilization is feasible and it is sustained. 2nd, therapy adoption increased, and it increased for all 5 medication classes. 3rd, there appeared to be a dose-response relationship. And 4th, this is a scalable strategy. All right, last slide. Look, I think that as somebody that still sees patients, and I love what we have the privilege to do that, I think CKD care is complex. We have vulnerable people we take care of. And within that complexity, I think the key thing to changing care is delivering the right information at the right time in the right place for that patient. This tool, it's very simple, 1-page visualization, brought that opportunity in the focus for real docs, seeing patients in the community, more than 15,000 at the end of the study, and really made a big difference for medication adoption. So we were super excited to see that. Finally, I just want to thank some people. So this kind of work doesn't happen from one person. I have collaborated very closely with Pulse Data AI, and we've been working together for over 4 years. We've created several models that we're using, and it's been really great. I want to acknowledge that. I also want to thank two members of the USRC team, Michael Katz, who's one of our analysts, and Stephanie Brillart, who works on the USRC research team. I also want to thank the physicians and leaders at Dallas Renal Group and South Texas Renal Care Group. And finally, I want to thank 2 people who are here, Dr. Jeff Block and Dr. Martha Block. They run the USRC research division together, and they really make opportunities like this to help people possible. And Jeff, of course, was my partner in this work, so thank you.
Great, Mike. We have time for one question.
Don't run away.
Don't run away. Yes, please.
Dr. Rothman, thank you for this great work. I was just curious if there are any plans to look at the durability of after a patient adopts the treatment, the durability of therapy, just recognizing that SGLT2 inhibitors and GLP-1s are often discontinued at a high rate within a year of initiation, and whether this tool actually optimizes that as well.
That's a great question. We are continuing to look and collect that data. So at this point, we haven't decided to do that, but I think that's really important. And I think that one of the things I'm looking at is how do I get beyond just adoption at the physician level to the next level, next layer that you're really talking about, which is patient actually getting the medicine and staying on that long term. So I think that's a key next thing. But I was trying to focus on, first, you have to get people to not miss opportunities at the point of care and actually prescribe the medicine. And I think that's an important thing that we need to do next.
Thank you.
Thanks.
All right, excellent. Our next speaker is Dr. Samaya Zaran. She is a transplant nephrology fellow at the Mayo Clinic in Rochester, Minnesota, and completed her nephrology training at McGill University, where I went to medical school. Oh. Always great to see an alum. Her academic work focuses on kidney transplantation with a particular interest in improving access to transplant. Thank you.
Thank you. Okay. Hi, everyone. Thank you so much for the organizer for the opportunity to present our work. I realize that you've been listening to care models and therapeutic tools. I have heavy immunology stuff, so bear with me. I have quite a bit of background here, hopefully to lay the grounds for my study. I have no financial disclosures at this point of my career. Hopefully this will change in the future. Just kidding. Okay, so our learning objectives today is to examine how microvascular inflammation behaves across the donor-specific antibody types, and to determine whether the inflammatory burden, rather than DSA alone, drives the graft outcomes, and to explore whether the overlapping microvascular inflammation and interstitial inflammation represent a distinct high-risk phenotype. And I was told we need to have a question for CMA. So I abided by the rules. So which of the following best reflects the current understanding of microvascular inflammation biology? Is it that MVI is primarily an antibody-mediated process, or MVI without DSA is clinically insignificant? Or is it that overlapping MVI and interstitial inflammation represent a higher risk phenotype? Or is it that cellular and antibody-mediated rejection are distinct and non-overlapping processes? I will move on for the sake of time. So when we look at why kidney transplants fail over time, you can see that early during transplant, when we look at those biopsies, we can see that there is barely any changes, and which is likely reflecting the surgical and technical complications, until it comes to a point at 6 to 12 months, where we see significantly higher prevalence of antibody-mediated rejection, whether alone or as part of mixed rejection. And so antibody-mediated rejection really is the dominant cause of late allograft failure, as you can see here. Even in patients who are adherent to treatment, it represents the majority of cases that is, in some studies, estimated to be 65%. And antibody-mediated rejection reflects an endothelial injury that is driven by alloantibodies. You can see here on this panel, donor-specific antibodies represented by anti-HLA DRB1 with impressive MFIs. So those antibodies, when they bind to the endothelial HLA molecules, they then trigger monocyte and natural killer cell recruitment, which in turn secrete cytokines and recruit even more cells. But then the other, on the right hand of the panel, the other effector mechanism that is triggered by HLA binding is activation of the classical complement cascade, which ends up with formation of the membrane attack complex and further tissue damage. And this pathophysiology is perfectly reflected on the kidney biopsy as we see it under the microscope. So from the left to the right, you can see evidence of complement activation, referred to as C4D, and those are represented in the brown lines along the peritubular capillaries. You can also see cellular infiltrate in the glomeruli, referred to as G, or in the peritubular capillaries, referred to as PTC, and both of them are referred to as microvascular inflammation. If the inflammation is severe enough, it then infiltrates into the intima of the blood vessels, causing vascular injury, or referred to as V. And over time, this severe inflammation fades away and is gradually replaced by chronic changes of irreversible damage, referred to as CG, as you can see as duplication of the membrane, of the glomerular basement membrane is in panel 5, or multi-lamellation at panel 6 under the electron microscopy. And this also in the blood vessels would be reflected as intimal thickening and arteriosclerosis. And each of these individual scores is graded from 0 to 3 based on the severity. So how do we make the diagnosis of antibody-mediated rejection? It's really based on the Banff criteria. And the Banff group is basically a group of HLA lab scientists and pathologists and clinicians who come together approximately every 2 years to come up with the criteria that guide us with the diagnosis and management of antibody-mediated rejection. So as of 2019, they had very simple 3 criteria. One is that you need to have tissue injury or microvascular inflammation on the left. 2, you have to have a serological evidence of donor-specific antibodies, or DSA, on the right. And then the evidence of interaction of those 2 elements, as you can see, is C4D deposition in the peritubular capillaries. But as simple as it is, it has its own limitations too. Limitations related to donor-specific antibodies and limitations related to missing the overlapping rejection concept that we'll talk about. So when we talk about the more we learn about the microvascular inflammation, the more we realize that the antibodies is not the whole picture and only part of the picture. About half of the cases we see microvascular inflammation without DSA, and we don't know the clinical significance of that. And even when we detect donor-specific antibodies, all antibodies are currently, in the current framework, are treated as a one entity, while we know that they do reflect different contexts, whether they were present before transplant or preformed or developed de novo after transplant. And so the difference between the de novo and the preformed antibodies were looked at about a decade ago, and that was all comers, not really related to rejection. And so you can see the black curve that represents patients, kidney transplant recipients with de novo DSA, have worse allograft survival compared to those with preformed DSA. But how does microvascular inflammation behave across the DSA subtypes is not really well studied. With regards to the second limitation, which is the fact that the DSA is absent in about half of the cases, the update on the Banff group in 2022 adopted a new group that's microvascular inflammation that is DSA negative and C4D negative, and that is really an evolving diagnostic category that we still continue to learn about. The second limitation for the Banff system is the missing concept of overlapping injury. Excuse me. So the current system classifies cellular rejection and antibody rejection as 2 different entities, but we know that there is an entity called mixed rejection that's not captured in the current classification system. Those patients have worse outcomes. And we know that the underlying pathophysiology of these 2 mechanisms of alloimmune injury are actually overlapping. So even though we traditionally separated rejection into antibody-mediated and cellular rejection, we know that in antibody rejection, there is a cellular element that includes natural killer cells and monocytes. We also know in the cellular rejection, there is an increased antibody recognition. And so our emerging data shows that rather than distinct rejection categories, we need to have a newer model that supports a spectrum of autoimmune injury that includes both of them. And again, this was also previously looked at over a decade ago, all comers, but from a cellular rejection perspective. And as you can see here, if a patient with cellular rejection had any evidence or any element that's shared with antibody-mediated rejection, so be it DSA positive or C4D positive, they do have significantly worse outcomes, as you see in the dotted line, with a worse graft survival. But how MVI or microvascular inflammation behaves when it concurrently exists with cellular rejection manifestations is not really studied. And so to summarize, we do have a current framework that treats DSA positivity and antibody-mediated rejection as a one entity, and that treats antibody rejection and cellular rejection as two separate entities, but we have a clinical reality that doesn't really go with that. We know that half of the cases, there's no DSA, and there is microvascular inflammation, and those with microvascular inflammation and positive DSA, we know that not all DSA are created equal. Some of them are de novo, some of them are preformed, and those reflect very different clinical contexts. And on the other hand, we have patients with concurrent inflammation within the cellular rejection and the microvascular inflammation that we don't know what to do with, or we don't know much about. And here's come our study. So we hypothesized that microvascular inflammation with concurrent tubulointerstitial inflammation is independently associated with worse graft outcomes across all the DSA groups. So we aim to characterize the histologic features of MVI across the DSA subtypes. We also aim to evaluate the association between the tubulointerstitial inflammation within MVI and discensored graft failure. We wanted to determine the prognostic impact and whether the overlapping MVI and cellular rejection actually reflect a higher risk phenotype that would support an emergence of a new category called the mixed rejection that we hope Banff will adopt. So we looked at our kidney transplant recipients retrospectively across the 3 Mayo Clinic sites who had only kidney transplant between 2010 and 2024, and that turned out to be about 11,000 patients. We excluded 2,000 of those because of incomplete biopsy data. And then we ended up having, and so we ended up with a cohort of about 9,000 patients and about 32,000 biopsies. Of those, we detected new microvascular inflammation or antibody-mediated rejection in about 1,062 of them, with a prevalence of about 12%. We further excluded 90 more patients because they had overlapping diagnoses. So our final cohort included 973 patients. We defined de novo DSA as those detected newly more than 1 month after transplant. If it was present before transplant or within the first month, we included that as preformed. And we abided by the definition of Banff for MVI and ABMR. And then we separated this cohort into 3 groups. The no DSA, which was about 46% of the patients, consistent with previous studies, and those with positive DSA had more or less fair share of preformed versus de novo, about a quarter in each group. I'm going to bring your attention to a few things in the baseline characteristics here. So the no DSA group had the oldest patients, about 60 years old, compared to about 45 in the de novo. The preformed DSA group had highest proportion of females, and that is consistent with the fact that females are more likely to get sensitized with pregnancy. Of course, we had a white majority between 2/3, approximately 2/3 to more than a half. I would say about our site in Minnesota that we do transplant a lot of highly sensitized patients and positive cross-match. So you can see in the preformed DSA group, compared to the other sites, we have close to 40% of these patients in the preformed DSA group. And even though we try to keep the de novo DSA as low as possible with long-term follow-up on the right side in the de novo group, we still have about 20% having de novo DSA, which is still quite high. In the de novo DSA group too, notably there was 2/3 of them recipients of deceased donors compared to living only 1/3. Furthermore, so we didn't see any difference in the cause of kidney failure across the groups, but we saw that the preformed DSA group had a higher proportion of those who received a kidney transplant in the past, causing this presensitization state. And this particular group received depleting immunosuppression induction in about 90% of the cases. And we noted also that the preformed DSA experienced rejection at the shortest interval after transplant, about a year, compared to 2 years in the de novo DSA. And we followed these patients between 5 and 6 years on average. So we looked at the mean Banff scores at the rejection diagnosis. You can see that the asterisk represents the statistically significant. So in the peritubular capillary group, you can't see my, okay. In the peritubular capillary group, there is a bit more average risk average score of PTC in the de novo compared to others, but what was really striking is that the tubule interstitial scores were actually significantly higher, almost double, in the de novo group compared to the other groups. When we did the multivariable analysis, though, we saw that DSA positive status would represent a high-risk group with 60% higher risk of developing rejection. But you can see down before the last is the I score, or interstitial inflammation, gives really the highest hazard ratio of 2.4 if it exists concurrently in the DSA for this censored graft loss. When we tried to make it a bit more visual, we looked at the KM curves. So we stratified all the patients only by the DSA status. Unsurprisingly, those who did not have any DSA in green had the best survival. Those who had de novo DSA had the worst survival compared and consistent with the previous study I showed you that was done a decade ago. And those with preformed DSA had intermediate survival. When we tried to stratify each of these groups by the interstitial inflammation score, we saw a clear and consistent pattern of worse survival with a higher interstitial inflammation score within the MVI. So this is the no DSA. Always in red, you will see better graft survival, and the other groups stratify beneath that, and we have a statistically significant difference. In the preformed DSA, the same pattern. The red curve that represents no interstitial inflammation had the best graft survival compared to others, did not reach the statistical significance. But then in the de novo DSA, we had a pretty robust stratification and separation of these curves. Finally, when we looked at the follow-up biopsy, we saw that persistent MVI was more common in the preformed or de novo DSA compared to the no DSA group. And we also saw that transplant glomerulopathy occurred much more frequently in the de novo DSA group, which likely explains their worse outcomes. So in conclusion, microvascular inflammation is not a uniform entity across the DSA groups. When we find features of T-cell mediated rejection, this is common, and then especially happening in the de novo DSA group, and it's usually associated with worse graft outcomes. So we hope in the future we try to refine the rejection classification. We hope the BAMF group would consider adding a new category for mixed rejection. We would hope that we move beyond the binary DSA-based framework and incorporate a lot more of the clinical context. And we hope to validate our findings in multi-center and prospective cohorts and try to evaluate treatment strategies to improve patients' outcomes. And I'm happy to take questions.
I think in the interest of time, we'll skip questions, but she will be available after this session. All right, so I have the pleasure to finish off this abstract session. Again, my name is Delphine Tuo. I'm a professor of medicine at UCSF in San Francisco, and I practice at the San Francisco General Hospital, which is our public hospital in the safety net. It's my pleasure to present on behalf of my co-authors, and in particular, Charlene Shirali, who is an enterprising second-year medical student who couldn't be here today. But if all of our medical students are like her, I think we have a very bright future, so very excited. All right, I do not have any financial disclosures. My learning objectives are to, one, appreciate the high cardiovascular risk among primary care patients with chronic kidney disease who have not yet received any nephrology consultation or expertise, and to learn about one potential population health approach to improve access to nephrology for this population. So it is no secret to this group that CKD affects millions of adults in the United States, and that cardiovascular disease is the leading cause of morbidity and mortality in this group. There are some good studies that have suggested that early nephrology care can slow progression of kidney disease, and these days can also slow progression of cardiovascular risk, thanks to a lot of the goal-directed medical therapies that have been discussed or identified earlier today. However, many patients with chronic kidney disease do not receive timely nephrology expertise despite this high risk. This is true nationally, right? We have a dearth of nephrologists nationally. This is particularly true in safety net populations, so populations like the one I care about who receive primary care in federally qualified health centers and have very few specialists for whom they are able to see. So identifying interventions to try to improve nephrology access to this population is of particular importance. So as an initial foray into this, we wanted to identify what proportion of active primary care patients in our safety net might benefit from proactive nephrology consult. If they're unable to see us, can we reach out to them in a proactive manner because of their high risk of because of their high cardiovascular risk or high risk of ESKD progression? So essentially, what I'm trying to do is to change the paradigm of a primary care provider requesting expertise to a nephrologist the other way around. Can we as nephrologists provide proactive nephrology expertise to the primary care providers and their patients as a result? So in our study population, we included everybody who has at least one visit in our primary care federally qualified health centers, which are about 12 FQHCs in San Francisco, aged 30 to 79, and had evidence of CKD by one ambulatory value of GFR between 15 and 60, or an abnormal urine protein, either defined by UACR, UPCR, or a dipstick. Recognizing this is not a perfect definition of chronic kidney disease. This is not sustained over 3 months, but this is just our foray looking into who our potential patient population might be. We excluded individuals who were pregnant during this particular time frame, active malignancy or hospice care, because they probably would not benefit from a proactive nephrology consult, and then anybody who's had interaction with a nephrologist, with one of our nephrologists. So that's either an in-person nephrology visit, a telehealth nephrology visit, and we have a very robust e-consult system where primary care providers request nephrology expertise electronically. So those are patients who do receive nephrology expertise just in a co-management fashion. We excluded those individuals from this cohort as well. So really folks with CKD who have not touched or been able to be touched by our nephrology group. This is just a flow diagram that identifies this. So we started with about 60,000 patients, identified those with chronic kidney disease, so that brought us down to about 8,100, excluded patients who had been seen by a nephrologist. It brings us down to about 7,300 patients. Some of these patients do not have all of the data available, so we did some multiple imputation to try to calculate two outcomes. One was the 10-year risk of atherosclerotic cardiovascular disease, using the PREVENT ASCVD score, and the other was their 2-year risk of end-stage kidney disease or kidney failure with the 2-year KFRE. So just very briefly, our 7,300 patients, as to be expected from a safety net population, this is a relatively diverse in racial and ethnic composition, as well as by language, which is not demonstrated here. Nearly 43% are active smokers, which always amazes me every time I see characteristics of our patient population. Not surprisingly, half have active diabetes. When you look at medication prescriptions, about 60% of them are on an ACE or an ARB, which is great. About 18% are on an SGLT2 inhibitor, which is better than the national average, so I give kudos to my primary care colleagues. And then about 56% have an anti-lipidemic, and then 74% are on antihypertensive medications. You can see here that most, so about 68%, had stages 1 and 2 chronic kidney disease, so essentially defined by proteinuria, and then albumin to creatinine ratio, and most patients had A2 or A3. So not surprisingly, among this group, over half of patients were classified as having an intermediate or high ASCVD risk score. As you can see here, about 48% had an intermediate 10-year risk score and 9% had a high risk. And then when you look at your 2-year KFRE, about 4.2% of patients had an intermediate to high risk of kidney failure within 2 years. And so we are hoping, again, this is our first step, but we are hoping to use these data to now think about how can we proactively reach these patients. Now, in the grand scheme of things, this is still quite a number of patients that our nephrology group cannot necessarily reach out to in a proactive fashion. And so we need to further hone down that group of patients using modeling. And our hope is to use this modeling to identify who are even the highest risk patients among those with a high 10-year ASCVD risk or a high 2-year KFRE risk score. And this really suggests that there's a utility for population health approaches, including proactive proactive consultations within our safety net population. And I will highlight that this is not a completely novel concept. Other groups have done this before, mostly in value-based organizations like Kaiser. Manisha Jam has done this in the Pittsburgh area, and so this is our attempt to do this within a safety net population where the supply-demand mismatch of nephrology is particularly stark. So I am hopeful for next steps to see if we can get our hands around all the patients who need us in San Francisco. Thank you for your time. I'm happy to answer any questions if folks have them. Perfect. With that, I will close this abstract session. Thank you to our wonderful speakers, and join us in the poster hall in about 10 to 15 minutes. Thank you so much.